Okay. Okay, so now we're going to talk about assessment of the heart and lungs, okay? Rebecca, is everything, am I okay in there?
Perfect.
Okay, just wanted to make sure that everything was okay. All right, so we'll start with the lungs, okay? So there's a lot of this that you already know and perhaps are doing based on some of your assessments in the hospital. Okay, so a little bit of a review. Your right lung has 3 lobes, your left lung has 2 lobes, okay? When you're doing your assessment, your respiratory assessment, your, what are you assessing with the respiratory assessment? What kinds of things are you looking at?
Sound.
The rate,
Depth.
depth, effort,
Accessory muscles.
are they using their accessory muscles? O2, SATs, pulse oximetry, some terms that you know already are tachypnea, PNEA, remember that? PNEA at the end, meaning having to do with breathing. So if somebody is tachypnic, high respiratory rate, right? If they're bradypnic or bradypnea, slow. How about apnea? None. APNEA, apnea, none. Dyspnea, difficulty. How about, let's see, what was the other one? Eupnea, EUP? What? Normal, right? Somebody's eupnic, they have normal respirations. So the normal respiratory rate, 12 to 20, okay? So all that stuff you already know. When you're auscultating lung sounds, remember to have a quiet environment. So ask visitors to step out. You do want to provide privacy as well. Pull the curtain. You're going to move the gown and put the stethoscope over skin, not over gown. And when you're learning, and you put the stethoscope over clothing or something, it makes a lot of noise, and sometimes it's hard to distinguish what you're hearing. So that's why I always say put the stethoscope on skin and not over the gown or patient's clothing or anything like that. You will train your ears so you'll know what you're listening for, because when you're listening to the lungs, you're still going to hear a heartbeat in the background. So, but until you're really used to that, the stethoscope should go right on the skin and not over the gown, okay? So, let's see. I'm gonna refer to this guy. Can you see over here?
Yep.
Yes. Okay. So you have a systematic pattern that you're listening to lung sounds, right? So you should listen anterior. You should listen laterally, and then in the back or posterior, you should have a nice S pattern of assessment, okay? So following a good pattern to really get a good listen to all lung fields, since your lungs start right up here and fill up the chest cavity, okay? So that's all stuff you already know, okay? So I am going to start out by talking about what's normal. There's 3 sounds that you hear in a normal lung, okay? Bronchial, I'm going to tell you what they are, and then we'll discuss them and break them down. Bronchial, bronchovesicular, and vesicular. See, I know this won't show up in the video, but I'll show the picture. Okay. Bronchial, bronchovesicular, and vesicular. So those are in the normal lung. Bronchial breath sounds are sounds heard over large airways. The trachea, right here, okay? So bronchial breath sounds, they're described as, let's see, loud, blowing, and high-pitched. Loud blowing, tubular, and high-pitched. So it's air going through a tube. So think of the trachea, because that's a large airway right here. Okay. So you would normally hear bronchial breath sounds right here. All right. So you can, I'm going to have you listen to yourself later so you know what they sound like. I do have some sounds through here, but some of it is kind of staticky, and some of it's pretty good. So most of the breath sounds aren't that good. But the mannequin in the back has good breath sounds and good lung sounds. So, okay. So those are bronchial breath sounds, large airway up here. Then, as the airway branches off, and it's a slightly smaller tube, it's bronchovesicular, okay? So these are sounds you hear on either side of the sternum. Bronchovesicular. And in the back, between the shoulder blades, okay, right in this area. Okay. So this is like blowing through a straw. The tube's a little bit smaller, okay? So we have, I'm moving down, we start here, then here, and now for the remainder is vesicular breath sounds, okay? So they're soft and low pitched, and I like that picture there. I'll show you in just a minute. Because you can see the branches, how you have the big branch, or the big trachea there, and how it branches off, and then how it branches off again to all those little branches. Can you guys see okay over here? Okay. So you can actually see the lobes of the lung, the left lung with the 2 and the right lung with 3. So that's a really good, I think, picture that shows you the bronchial, the bronchovesicular, and the vesicular. So the vesicular breath sounds are what you hear over most of the lung periphery, okay? Most of the lung periphery. This is a good one too. So you see the top is A, the A part there is the bronchial, and then B, the bronchovesicular, see those little dots? It tells you where you hear each of those. Can you see that in there? Closer. So-so?
So-so.
So-so.
Kind of glares from the light.
Glares a little? Well, okay. So bronchial, bronchovesicular, vesicular. Those are the normals. Okay, and that just shows you all the different angles, the front, the side. So those are the normal breath sounds. Sounds you hear in the normal lung, okay? So now we're gonna talk about adventitious breath sounds, or the breath sounds that you hear, or sounds that you hear in other than the normal lung. Okay, so bronchial breath sounds could be abnormal if you hear those loud blowing sounds in another area, okay? So you should be hearing them, we know, right here over the trachea, but if you hear them somewhere else, then that's abnormal, bronchial. So if you hear bronchial breath sounds, maybe over here in the left lower lobe, then that's telling you that there is some consolidation there. So maybe a pneumonia. Turn him on in a minute. Okay. So bronchial breath sounds, if you hear them in a place other than over the trachea area, abnormal and indicative of consolidation. So if you know your patient has a left lower lobe pneumonia, listen very carefully in their area to see what you're hearing, okay? And again, when you are listening, you should listen until you make sure you identify those sounds you're hearing before you move on, okay? So maybe it sounds clear over here. I'm hearing those loud blowing sounds here because of that pneumonia. Okay, so bronchial breath sounds in any other place abnormal. Okay. Crackles. Anybody hear a crackle before?
Heard him today.
Heard them today? What was going on with your patient?
COPD,
pulmonary fibrosis.
So where were the crackles from? Fibrosis? COPD, you don't generally hear crackles. You could, not all the time, but
Well, she says that's what.
probably from
It's
the lung
normal,
disease.
It's always there, yeah.
It's always there.
That's what she said, yeah.
Did you hear that there's CHF?
CHF. Because air is going over fluid, so that you hear the crackle sound when air is passing over fluid. So CHF is a good example. Pneumonia sometimes
Yeah, she
sometimes
definitely
pneumonia.
had a cough, she was having a hard time,
Coughing and bringing stuff up.
bringing stuff up, yeah.
I bet there was some interesting sounds there. Probably a lot of different ones. So, what did it sound like? Can you describe it, or it's hard to just put them
Yeah,
into words, I
it
think,
is.
but, he's got some crackles. A lot of the sounds that I put on here, as I put it on the speaker, the speaker's kind of staticky and I kind of distorts it. But what I think to describe crackles, it sounds kind of staticky, is what crackles sound, kind of like that. What do you think? Popping?
Like bubble wrap.
I was gonna say.
Somebody
tissue
said
paper
a whole bunch of bubble wrap twisted up, and when it goes pop, 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 that's kind of like crackles. So,
or- Cindy told us today that it's.
yeah, rub
taking-
your hair
Yeah.
next to your ear,
Next to your ear.
like
Yeah,
that.
that's more,
Yeah.
to me, what it's,
Snap, crackle, pop. Somebody else said one time. Um,
Or when you're snorkeling and you get water in your snorkel and you're still breathing. Have you ever heard of that? I'm sorry.
Oh, wow. That sounds kind of serious, I don't know. Let's see if I can find some.
If only we had time for that.
Let's see.
you don't know.
I have to use the scope here, but, see, I might be able to find a crackle. Let's see. Can you hear that? Some of it might be staticky, but that's what crackles sound. And those are coarse crackles. Coarse crackles are really loud. If you hear it described as fine crackles, they're a little fainter. I think I have fine crackles on here. Let me see if it sounds it. Okay.
Is that new, Anna?
Pardon?
Is that new?
No, it is not. No, not new. That little at the end,
Oh, yeah.
kind of. Yeah, it's hard to distinguish between static from the speaker and if it's really crackles. The lung sounds are so-so on this guy, like that. But he's got some other good things about him, so we'll keep him around. So crackles. So CHF is a good example. What would you do if somebody had CHF? What's the drug you might give them? Lasix. Furosemide, Lasix, yeah.
That's what my patient was on.
On Lasix, yeah. Yep, there you go. So that is crackles. Air passing over secretions or fluid. Wheeze or wheezing. I bet most of you have heard a wheeze somewhere along the line. Yep. What's happening with wheezing is the airway is narrowed and the air's trying to push through a narrowed passageway and it makes a musical sound. Musical, so they say, right? Let's see what I can find here. So COPD, you might hear it. Who else?
Asthmatic?
Yeah, asthmatic. There's a couple different wheezes here, so there's a couple sounds. Let's see. You can hear that one.
It's creepy.
Sounds like a ghost.
Good sound for the haunted house and the body parts. The other thing, which I didn't mention with the crackles, But that's important, is it on inspiration or expiration? And exactly where did you hear it in the, on the chest, or anterior, posterior, left, right? So where did you hear it? Okay, and so with, same with the wheezing, it could be inspiration, it could be expiration. And whereabouts did you hear it? Okay, so that's, there's another wheeze here. Let's see. Gives you a little menu here, so you can, if you want to, later you can practice with this. And there's another little, it tells you where to put the stethoscope on the chest in order to hear those things. You have to have that special scope. The one in the back, once I turn around, then you can use your own scope to listen, okay? So this is another wheeze. Let's see. Yeah, you gotta get it just in the right spot here. Can you hear that? Okay, so that's wheezing. So how could you treat this patient with the wheezes? What would be? Bronchodilator. Yeah, bronchodilator. Exactly. So maybe the inhalers, maybe nebulizer treatment, something to help open up those little airways. I'm going to just put the other picture back on. I'm going to have to make copies for the people who are watching this on video, I guess. Bronchodilators. So at CMH, you have to call respiratory for those. All right. Rhonchi, R-H-O-N-C-H-I, rhonchi. Rhonchi sound like a snore. Anybody hear that?
Yeah.
So if you hear some rhonchi, it might be because the patient needs suctioning, needs coughing and deep breathing. Might be like a kind of thing where they can maybe do some coughing and deep breathing to bring up some secretions. Okay. So if you have your ICU patient, and I know some of you have been in ICU, haven't you? Or you're getting ready to go, if you haven't been yet, and you have your patient on a ventilator and you start listening anterior and you hear some snoring-like sounds, it might mean they need to be suctioned.
Or the cuff is lost air.
Yeah, or their cuff is losing air, right?
You could hear it,
Because
the snoring got worse.
Yeah.
Mhm.
they were snoring probably without the stethoscope. Yeah. So that's what it sounds like, a snore. Or maybe it's your post-op patient who, let's see, they were done yesterday, and this morning as you listen to their lungs, you're hearing maybe a lot of snore-like sounds in their posterior lung fields. It might be because they need to move around, cough and deep breathe. Post-anesthesia, a lot of times, you have to open up those bronchioles and alveoli to get them moving. If they're all night sleeping, maybe laying down and not taking deep breaths, once you cough and deep breathe them, or use the incentive spirometer. You know the incentive spirometers? I see, now it's good. But you suck in on it. It's a good lung exercise to have them take some good deep breaths. So then you would document maybe, let's see, rhonchi auscultated over posterior lung fields, clear with coughing and deep breathing, or incentive spirometer. Something like that.
Can you repeat that? Rhonchi located.
If you heard rhonchi and you did some coughing and deep breathing with them and then it's improved, then you would document just what you did. So, rhonchi auscultated, what did I say? Posterior lung fields. So where did you hear it? Clear with coughing and deep breathing. So that's important to know. Let's see. A friction rub A friction rub occurs when the pleura become inflamed. And then the pleura rubs against the lungs, and then it's kind of like a, I don't know, I describe it as rubbing leather. And it's real painful because there's the pleura that covers each lung, and there's a small amount of fluid between, in that little space. The pleura is the covering in the lung, and there's a little bit of fluid to help with lubrication for, as the lungs inhale, exhale, so it helps with the lubrication. And when that lubrication is gone or lost, then you hear a friction rub. I don't have one. She's got one in the back. She's got one, I think. Oh, I do have one. Wait a second. I just... Okay, let's see what it sounds like. Yeah, it's painful too, because they don't want to take deep breaths because it hurts so much. So they need pain medication, and they're high risk for pneumonia because they don't want to take deep breaths. Friction rub. Anything else? Any other questions, comments?
Strider.
Oh, Strider, thank you, Strider. Strider. How come I don't have that? I write myself
So
in.
high risk of
A pneumonia because, infection too, but pneumonia because they don't want to take deep breaths because it hurts. So, it hurts too much. So Strider is from an upper airway obstruction, and you'll hear that on inspiration, that so maybe somebody who's having an anaphylactic reaction,
Can you say it again, what is that?
upper airway obstruction, okay? Upper airway, so that most of the time when someone's having Strider, you don't even need a stethoscope to hear it. You can be down the hall and hear it.
Is that like with whooping cough?
I was thinking about that.
Whooping
They're
cough.
like,
I don't know about that. Are they losing their airway with that?
Whooping cough is usually the bronchial.
Yeah.
That's, I think that's
Strider's
down a
usually
little
up
bit
in the-
further. Strider is more upper airway. I wonder if it sounds the same.
What is it?
It sounds similar.
I'm trying to remember what my
Also,
son
choking
when he was
victims
little,
get the
wasn't-
Strider.
Yes,
Yeah,
yes.
because when my son was little,
Somebody
I
was
can't think what he had. I can't think of what it was called.
It's usually chicken.
But
Chicken?
they gave him a shot.
Yeah.
A chicken, like a
anaphylaxis.
chicken bone or just
No,
chicken?
chicken.
Piece of chicken that gets
What's
lodged?
an anaphylaxis?
A lot of kids with chicken nuggets.
Anaphylaxis? Oh, that they were
Usually
having,
it's
oh, chicken nuggets. Somebody was telling me in one of the other classes that her baby had a marble in her throat and she didn't even have any idea, and she was hearing the and
She could breathe around the marble?
barely. And she was trying to do the Heimlich and she said she wasn't having any luck, and she did call 911, but then she started, I think, with the back blows, and when she stuck her finger in the mouth, the marble popped out. And she has no clue where the marble even came from, but she heard that Strider kind of, because there was that airway was completely blocked, or maybe there was this little teeny, where that marble came from. Yeah, baby, like
Well, my son, when I can't
Similar?
remember what he had, but they gave him a shot because they thought it would reduce the inflammation.
Uh-huh.
Because they said typically
anaphylaxis.
in an
You probably
adult,
give them epi or
it would have been
prednisone.
like laryngitis. An adult,
Oh, epiglottitis.
Where they have a little
yeah,
infection
he
in
just,
the.
no, not, he just had
epiglottis?
swelling of some sort, and he said adults would, present with laryngitis.
Yeah.
But it didn't help, so they actually sent him, when we brought him back, they sent him to x-ray to make sure he had
That there was
aspirated on something.
Something.
yeah.
And then they ended up giving him another shot and then it cleared up.
Oh.
I can't remember
I
what
know.
it's called.
Hmm.
It's not, it wasn't whooping cough.
So what? No.
but
I think he's got some strider here, so. If you're hearing, yeah, you need to intervene right now, stab. Yeah. So, with a lot of these sounds, you'll see other symptoms as well, you know, like turning blue, or their pulse ox is dropping, they're physically in distress. So, with the baby, she said she was turning blue.
I had it one time to a shrimp allergy, and I'm like not a person who's ever been allergic to shrimp, but I ate like seafood within a couple of times that week, and he said maybe it was just too much, and I ended up having a sore throat first, and then it turned into where I felt like I couldn't get any air.
Oh.
And I had to go
So
to the
then what?
hospital
Did you get
also.
some
Yeah, I had to go to the hospital, and they gave
epi
me
or
a shot or
um,
something
to help
Yeah.
that? Oh.
Can you show me the right position when you listen to the lungs correctly? Because sometimes when I listen to the patient.
Where to listen to the lungs?
Yeah,
We can do that later.
I put everywhere.
Right.
I want to be the best
Right.
spot that I can.
We can do that when we're done with this part, absolutely, because, yeah, that's something that you should be doing right now. So you want to listen to all fields, because, you know, the lungs take up a big, the whole chest, really. I have another picture I'll show you, so when we get to heart, too. So there's 3 more things related to the lungs before we switch over to the heart. They're called voice-transmitted sounds, which maybe you've never seen in the hospital. Do you ever do them, the voice-transmitted sounds?
Yeah.
Do you? I've seen them in doctor's offices, but not a lot in the hospital, unless it was maybe an emergency or something. Or maybe if you're working on a night when there's no power and the hospital's running on generator, and so they're not doing a lot of x-rays and running the CAT scanner and things like that. So you know that stuff happens for real. So these are voice-transmitted sounds. So I have 3 of them. One's called bronchophony, B-R-O-N-C-H-O-P-H-O-N-Y, bronchophony. So what you do is you have the patient say 99, and it's all posterior, okay, posterior. So you just take your stethoscope and you listen. Wow, they say 99, 99, 99, 99, all the way through your S pattern, okay? Normally, it should be muffled or unintelligible. So as you listen, well, that would be a fun thing to listen to each other with that as well. It'll sound like, it'll sound kind of unintelligible. Now, if there is a pneumonia or some sort of consolidation, it will be clear. It'll come through clear. So, CC, clear with consolidation. So maybe it's the night when, let's see, you had the hurricane or the horrible snowstorm and the power went out and the hospital's running on generator. So if you use your good assessment skills, or something like this might help you to figure out what's going on here, because in this left lower lobe with the pneumonia, it'll sound 99. So it sounds clear with consolidation. It'll help you figure out what's going on and maybe not delay treatment. Okay. So the next one is egophony, E-G-O-P-H-O-N-Y, egophony. And with this one you have the patient say E. E, 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 E. Same thing throughout posterior. And the E will sound like A with consolidation. Okay? E sounds like A. So this goes back and forth between normal and abnormal. Okay? A, E, A, that's supposed to be E. use these techniques, you would get used to it and you'd be able to pick up on it. Maybe you're gonna use it when you are a nurse practitioner working in private practice or in an internal medicine office or something like that. So, E sounds like A.